Good morning and good afternoon, everyone. Thank you for joining our third session in PointRight's PDPM education series. Today's session will focus on ICD-10 codes and the drivers of PDPM. A few notes before we get started. The panel at right houses both the session audio information as well as a Q&A panel. Please submit any questions you have, and if we do not get to them in real time today, we will certainly review them for follow-up. You can also find the session's handouts in the panel at right. The session will be recorded and distributed to all attendees along with a link to the session handouts and your CEUS survey, so keep an eye on your email after our presentation. Now I'd like to hand it off to today's presenter, PointRight Senior Healthcare Specialist, Jen Gross.
Thank you, Allison, and thank you all for joining us today. A very exciting presentation we've got going on, a little more exciting than I anticipated originally, and I'll tell you why in just a few minutes. So our third session in our PDPM educational series is talking about ICD-10 coding, those diagnoses that are so important to driving an individual resident's PDPM rates in multiple clinical categories. So before we dive in, I just want to go over our disclaimer again. The situation with PDPM over the next several months is going to continue to evolve. So PointRight is trying to stay on top of providing this education, but just keep in mind that this is based on the most current available that we have, information that PointRight has from CMS at this time. But as you know, PDPM is going to go in effect as of October 1st of 2019 for fiscal year 2020. So as soon as we know things, we will tell you in our PDPM educational series. But first, I'd like to do a little brief recap of our two previous sessions. You know how like when you're watching a TV show and they do a little recap of the previous episodes to kind of get you caught up. This is sort of like that, only less entertaining. So first of all, let's start off with session one. Our own Pam Kaiser gave us the basics, a rundown of and high-level overview of PDPM. Why PDPM was implemented in the first place. CMS wanted a way to set reimbursement based on individual resident or patient characteristics rather than the amount of therapy that the facility was providing for that patient, as well as incorporating all those ancillary costs that really can mount up that under RUG-4 facilities are not really reimbursed for. PDPM is also reducing the number of required MDS assessments that are needed to establish those payment rates. And there's a built-in payment adjustment for a few of the payment categories. We've got a full house. So let's, so the per diem payment, sorry about this. The per diem payment adjusts automatically over time the longer the resident remains in the facility. And there are many more case mix components that are involved in determining the payment. When we talk about case mix adjustment, this is based on resident characteristics. So when we're capturing those resident characteristics, this is often based on things like ICD-10 codes and other treatments and conditions for a resident that would inherently cost money to care for. So that is factored into the adjustment for determining payment. We have a recording of this webinar that Pam gave, so you can access that from our website. The URL's on the screen. So our second session was presented by our Paula Di Natale, and Paula talked about the non-therapy ancillary piece of the PDPM structure. So those NTAs, the non-therapy ancillaries, are intended to capture those pieces of resident characteristics that drive variance in the cost of care. You could have two residents that are receiving the exact amount of therapy and have the same ADL levels and even the same diagnoses to a certain extent, but one resident might actually cost more to care for than for another based on other characteristics that are inherent to that resident. And in RUG-4, currently that is totally not captured because the basis of the majority of RUG-4 reimbursement, as you know, is how much therapy you're providing for that individual. even though the NTAs are baked into the nursing component of RUG-4, it's not really called out specifically. Now, CMS did a lot of analysis to come up with this list of non-therapy ancillary comorbidities, and they came up with the top 50 conditions and services that SNFs spend the most money on to provide care for the residents. And these conditions were weighted by how costly each of those conditions are. And then when you figure out a resident's NTA classification, the number of points based on the number of conditions that that resident has determines where, what NTA category bucket that reimbursement will go into. And the NTA items are captured on multiple sections in the MDS. We're looking at bowel and bladder, diagnoses, swallowing and nutritional status, sorry about that, skin conditions, and special treatments and procedures. So lots of information that's baked into that non-therapy ancillary and a lot of moving parts. So Paula's recording is also available on our website. Now let's get to today's webinar. And I thought I would start off by telling you what this webinar is going to be and what it is not going to be. So my intent today is that to give you a good grounding in how ICD-10 coding and other diagnosis coding apply in PDPM, and give you some general guidelines for coding in ICD-10, and give you a couple of examples to direct you towards good practice in coding your diagnoses and how that applies when you capture those diagnoses in PDPM reimbursement. But what this is not is an ICD-10 coding training. I am not a certified coder, although I have been trained in ICD-10 coding, so I certainly would not take a class from me. So please, if you have not already, go and seek out an in-depth ICD-10 educational program. There are tons of them out there by very, very good teachers that are certified coders, but the earlier you get this information, the better. So today's learning objectives for this presentation is to give an outline of the patient-driven payment model, or PDPM, clinical categories that are driven or impacted in one way or another by diagnosis coding. We're going to talk about the pieces of the minimum data set, or MDS, that capture those ICD-10 codes that place the resident into those clinical category buckets. And we'll talk about some strategies to help you build systems in your facility or in your corporation to make sure that you're accurately capturing diagnoses way before October 1st hits. So we've seen this picture before. You'll probably see it many, many times in the future. This is a nice little pretty presentation of how the different case mix components combine into the residence rates in PDPM. So if you look at these different components, most of them are actually impacted by diagnosis coding. So in a tabular view, it's a little bit easier to see all the different drivers of these case mix components. So first of all, we're looking at the primary reason for SNF care, which is driven by a diagnosis, a single diagnosis. The PT and OT, physical and occupational therapy, case mix classifications both use the same primary reason for SNF care. They kind of go hand in hand, they're grouped together. Same goes for speech language pathology or speech therapy. The primary reason for SNF care would place the resident into a clinical category. Now, for the non-therapy ancillaries, as I mentioned earlier when I talked about Paula's previous presentation, a lot of those NTA comorbidities are driven by ICD-10 diagnoses. Not all of them, but a great number of them are. So being able to capture those comorbidities with a high level of specificity will help you make sure that you're fully getting reimbursed for those non-therapy ancillaries. Now, I'm sure you're wondering, well, what about the nursing component? Nurses care about diagnoses. Well, of course we do. So nursing component is partially driven by clinical information from the MDS assessment, but not ICD-10 codes, interestingly enough. That actually kind of surprised me when I was first reading the logic for calculating these clinical categories. But I will talk about the nursing component a little bit later. So I did promise you some basic tips and rules for coding ICD-10. So let me give you the Cliff Notes version. Again, this does not in any way qualify as a full ICD-10 coding class. So don't take me to the bank, but this is should be enough to get you started and give you a basic grounding and understanding of what ICD-10 is. So ICD-10 CM is the International Classification of Diseases 10th revision clinical modification, and this is international. And the intent is that if you go on a vacation in China and you fall and you break your left leg, the same code would be used for that diagnosis in the US as in China, even if the language that the doctors are speaking in those two different countries are totally different. Now, the US kind of lagged behind the rest of the world in adopting ICD-10. We stuck with ICD-9 in all US healthcare settings up until October 1st, 2015. I'm sure we all remember going through that transition, and there was a lot of education that was done about that around that time in ICD-10 coding. Now, the intent of ICD-10 is to classify patients based on different morbidity characteristics for diagnoses and for the reasons for an encounter in a healthcare setting. Now, when you go to buy an ICD-10 manual, you're actually going to see two different manuals. You need the ICD-10 CM manual. That's the clinical modification, CM. This is the diagnosis classification. The other manual is the ICD-10 PCS, or Procedure Coding System. This is what is used to code inpatient procedure classifications. So post-acute care really doesn't use those. They're not really related to PDPM classification. So, you know, if the one manual is enough, trust me. So the structure of an ICD-10 code. The codes can be anywhere between 3 and 7 characters, and there's a decimal point after the third character. Now, the hard and fast rule here is that you code to the highest level of detail possible for that diagnosis. So if there is a 7th character that is required for a diagnosis code, you need to code it. The 7th character often encompasses encounter codes, and encounter codes are basically what is causing this diagnosis and how recent is it, in a very layman's term. So a letter A, for example, indicates the initial encounter for a specific condition, like a broken leg. Now, this is usually a code that is used in the acute care setting because that's the immediate treatment for that injury. But not always. Initial encounters can happen in post-acute care. You just don't see it as often. Subsequent encounters are what we usually see in post-acute care. So after I break my leg, let's say I have to go to rehab for some reason and get physical therapy, that I would be capturing the subsequent encounter for my broken leg ICD-10 code. Now, this is a little bit of a different perspective from how we used to code in ICD-9, and for several years in ICD-10, we're used to using aftercare codes for a lot of conditions. Technically speaking, for an injury, what you code is a subsequent encounter rather than an aftercare code. And then there's sequela. The letter S is sequela. That's other complications that might arise as a result of an acute condition. Scar tissue buildup from a previous condition, for example, might be a sequela of another condition, another acute condition. Another piece of these codes is laterality. So anything that you have two of, there's a left side and a right side, or you could be bilateral. You need to code that where it's bilateral for your upper lower extremities, for your eyes, for your kidneys, you know, whatever you have two of, you need to make sure you code what side that is on, or bilateral. So here's what an ICD-10 code looks like, and we'll break that down. So let's say I have a patient who is admitted for rehab after a closed, non-displaced fracture of the right hip, and that's a right femoral neck fracture, technically speaking, with routine healing, no complications. So that code is S72.001D. So what are the pieces here? So first of all, we have S72.0. That's the fracture of an unspecified part of the neck of the femur. And you can actually get a specified part if you have the diagnoses to really capture that. But in this case, unspecified should be sufficient. 01 indicates the right side. D is the subsequent encounter with routine healing. So all of these pieces together tell the story of basically that sentence that I have at the top of the screen. Now, those are the basic do's of coding ICD-10. Of course, there are a lot of don'ts, and here are a few that you often come across just because of whether they're bad habits that are left over from ICD-9 for you old-timers like me, or other things like becoming rushed or not having sufficient documentation to feed into those diagnoses coding. The first code is a really big don't, is using an unspecified code if there is a more detailed diagnosis that is available. So, for example, an unspecified laterality, a fracture of the humerus. Well, I'm assuming the patient has two arms and one of them got fractured, maybe both of them. If it's a really unfortunate situation, you would code left, right, or bilateral. Other issues like just a basic code for COPD without any more specificities, to say with exacerbation, without exacerbation, something like that. There are a lot more pieces that make ICD-10 codes as specific as they really are. So don't just fall back on using unspecified codes if there is a more detailed diagnosis available in the documentation. Of course, leaving out those required characters, your manual will tell you, your code manual, ICD-10 manual will tell you if a particular code requires a fifth, a sixth, or a seventh character. You can't leave those required characters off. There are symptom codes, but if there is an underlying diagnosis in the documentation for what is causing that symptom, you're not going to code the symptom, you're going to code the diagnosis, and there may be more detail in the diagnosis to say with that symptom. So, coding for hyperglycemia, if there's a diagnosis of diabetes in the record, you're going to code that diabetes with the specificity that you need. And there are these things called combo codes, speaking of diabetes. There are two separate codes for something like an ulcer and something like diabetes. But if it's a diabetic foot ulcer, there is one single combo code that you would select to describe a foot ulcer, a diabetic foot ulcer, under the coding set for diabetes. So it's very, very detailed, but you can also get really right to the point. Now, there are these things called return to provider codes. Certain codes, certain ICD-10 codes, if you put them on a Medicare claim and submit it to CMS, they will trigger a message called return to provider status because they're not specific enough. If you're submitting it on a PDPM claim as a primary diagnosis, it's going to kick back, basically. And these are, again, codes that are not specific enough. And if you think about historic common coding practice, you might think that a lot of these codes that we're used to capturing the reason for therapy under RUG-4 would be kicked out. So MCC 2.81, generalized muscle weakness, R62.9, unspecified abnormalities of gait and mobility, R13.10, dysphagia unspecified. Any of those sound familiar? Those would be returned to provider codes. And as I said, there's nothing wrong with the codes themselves. They're just not specific enough, and you should be able to get a higher level of detail on that. And PointRight actually looked into this a few months ago. We looked at all the 5-day MDSs from calendar year 2017 in our database, so just 500,000 plus MDSs, and we were looking to see how frequently those return to provider codes were coded in the first line in I8000A. And the winner here was M62.81, generalized muscle weakness. Again, sound familiar for a lot of reason for therapy. And that came out to, over 57,000 MDSs, or 9.85%, which, doesn't seem like a huge amount if it's less than 10%, but if you have almost 10% of your Medicare claims that are rejected, that becomes a big problem. So think about the potential impact of this when you're looking at your common practices for selecting a primary diagnosis, and how many of those claims would be rejected. Now, of course, it's not the end of the world. You can revise a claim, you can make sure that the diagnosis is captured correctly and resubmit, but that takes time and it takes effort. So getting it right the first time is certainly in your best interest. So let's move on from generalized ICD-10 coding information to talking about how ICD-10 impacts PDPM. So, of course, almost all of this is captured from PDPM, except for the HIV/AIDS diagnosis, which is captured from the Medicare claim. Everything else comes from the MDS. And not just any MDS, but the 5-day MDS. Now, the 5-day is going to continue into PDPM. The ARD window has been extended to capture those grace days, so they're no longer grace days. It's basically one ARD window from day 1 through day 8. You can pick any day in that window and set your ARD, or assessment reference date. Now, the clinical classification. So an ICD-10 code would put a resident into a clinical category. That clinical category would remain the same for that resident unless the criteria for an IPA, an interim payment assessment, are met. An IPA is like a significant change assessment. It resets one or more of the payment components effective with the assessment reference date of that assessment through the end of the Medicare stay, unless there is another interim payment assessment that is completed. So that basically shifts the payment if there is a change in the resident's condition that would be enough to change the payment. Then there's the PPS discharge assessment. That's the third piece of the required MDSs. Now, this does not affect payment, but CMS is looking at them. They're going to be using this information on discharge to audit therapy utilization throughout the entire PPS stay, and there are going to be more items added to the PPS discharge item set to do so. Now, speaking of adding MDS items, I mentioned earlier that this is a little bit more exciting and entertaining than I thought it was going to be when I was first developing this presentation. Last week, this is the week after Thanksgiving that we're recording this, last week on November 19th, 20th, right before Thanksgiving, CMS released their PDPM website. I'll give you the link to that at the end of the presentation. And it includes tons of information as well as some new MDS items that are going to be in the fiscal year 2020 item set. And one of those pieces is relevant to today's presentation. They're going to add a new MDS item, I0020B, for SNF primary diagnosis, which is going to be used to capture the ICD-10 code for the primary SNF diagnosis in order to map those clinical categories for PT, OT, and speech. Now, if you have read the fiscal year 2019 final rule that broke down all the pieces of PDPM, they originally said, oh, just code in the first line of I8000. Don't need to do that anymore. There's going to be a specific MDS item to capture that. Now, I0020, primary medical condition category that we already have on the MDS, that's not going away. So don't let this confuse you. You are still going to need to capture that primary diagnosis in I0020B. So other ICD-10 codes will be coded in I8000. They'll drive the other comorbidity components in speech therapy and the non-therapy ancillaries, but the primary diagnosis has been pulled out and put into a standalone MDS item, or it will be, rather, next November. Now, where do diagnoses come from? Of course, only specific people are enabled in their scope of practice to diagnose: physicians. physician extenders, who are nurse practitioners or physician assistants, depending on the state scope of practice that you're working in. So these are not therapists. These are not dietitians. These are not psychologists. They are only MDs or physician extenders who can write a diagnosis, and these diagnoses have to be documented in the record in order to code something on the MDS and put it on the claim. So if you get information from the resident, from their family, from a consultant about a diagnosis that they have that's not in the record, you do need to consult with the doctor or with the nurse practitioner to get that in the documentation so you can capture it. Of course, you're going to get paperwork from the hospital or electronic information from the hospital with diagnoses on it. Don't go straight to pulling those diagnoses and putting them on in your record without first confirming with the physician that they're still active in the SNF. There are going to be hospital diagnoses that may still be relevant to the SNF stay, maybe as a subsequent encounter, and others will not. So take that into consideration. But you do need your own docs and nurse practitioners to document in the record. Now, other practitioners can add more detail to make a diagnosis more specific, such as a pressure ulcer. Chances are the doc is not going to be staging that pressure ulcer. A nurse will be. They can document a pressure ulcer. You can make the specific code for the stage of that pressure ulcer, for example. Now, this primary SNF diagnosis idea is something that is new to skilled nursing facilities to a certain extent. It may not be the same as the reason for the inpatient hospital stay. Most of the time it is. It's direct rehabilitation or skilled services following a specific diagnosis that placed the resident in the hospital to begin with. Most of the time they're going to be the same or align with each other. But there may be a secondary condition that arose during the hospital stay. Maybe the patient was going to go home, but they developed pneumonia, so they have to go to the SNF for a while and rehab for a while before they go home. So that might be the primary reason for the SNF stay. Again, you have to decide that on a case-by-case basis. Now, most of the time, of course, a SNF admission is for rehab from a condition that's related to the prior hospital stay. You're going to code for the condition from the prior hospital stay. So if I admit a resident for rehabilitation after a hip fracture, you would use the code for that fracture as a subsequent encounter as the primary diagnosis, if that's the reason for the SNF stay. Now, sometimes you're going to see aftercare. If the reason for the SNF admission is aftercare, you can use the aftercare Z code, but the classic example of this is aftercare following a joint replacement surgery. There's a Z code for that. But remember, aftercare does not mean following an injury. It's aftercare following a procedure. Two different things. And again, a good ICD-10 coding course would cover that in great detail. So when you're determining the primary SNF diagnosis, of course, this is an interdisciplinary process. You need to discuss with the physician extender, with the therapy department as you're planning the care to say, hey, what's the reason why Mary is in our SNF right now? And what's the primary driver of her stay? So this requires a lot of discussion. Make sure that all the interdisciplinary team members get their input. There may be outside specialists or consultants that are involved as well, maybe for pain management or wound care, for example. But a lot of our residents do have multiple medical conditions that require treatment in the SNF. So this is actually right from the documentation that CMS released about this I0020B MDS item. What is the main reason this person is being admitted to the SNF? Interesting philosophical question, and sometimes you might need to have a lot of discussion surrounding that. So let's move on to what that primary diagnosis does. It sets clinical categories in some of the payment components. First of all, PT and OT have clinical categories that were collapsed together because they're so similar that distinguishing between them is kind of meaningless for research purposes. So CMS put together these joint replacement or spinal surgery, non-ortho surgery, and acute neuro, other orthopedic and medical management clinical categories. So those are collapsed together, and these are all driven by ICD-10 codes, the primary diagnosis. Now, for speech-language pathology, there is one clinical category, acute neurologic. Either a resident would be in that category or not in that category, so there's not a selection of them. These diagnoses on the right are all from ICD-10 codes. But there are a couple of diagnoses on the left-hand side that I want to point out to you. These are not driven by ICD-10 codes. It's actually specified that you need to check off the checklist item in section I to capture those comorbidities. So you might have a primary diagnosis on the right-hand side and one or more other comorbidities that are checked off in the checklist. Those add up, as we'll see in the speech-language pathology payment component. Now, if we look at the non-therapy ancillaries, again, in the last presentation, Paula went into great detail on this information. And it's basically a count of how many of these NTA-related comorbidities were coded on the MDS, starting off at the very top with HIV/AIDS at 8 points and then going down through the list. So comorbidities that are more expensive to care for have more points. You will see some comorbidities that are coded, that are called out as MDS item I-8000. Those are the ICD-10 codes. So lung transplant, major organ transplant, opportunistic infection, those are all ICD-10 codes. But also notice that there are other diagnoses like MS right above there, I-5200. You have to check the box on the MDS to capture that comorbidity. Now, capturing these comorbidities for ICD-10 codes, you can code anywhere in I-8000, especially now that that first line, the primary diagnosis, has been freed up. It actually doesn't matter what order you code those in. They will be captured if you code the appropriate diagnosis in I-8000. But as I said, don't forget the checklist. It's really, really important to make sure that you're getting the good codes in I-8000. But if there is a checkbox item for a diagnosis, make sure you check it off. Those checklists are actually used, not just for PDPM, they're also used in quality measures, for example. You want to make sure you check those items. So the diagnosis checklist is used for, as I said earlier, some of the speech-language pathology comorbidities, some of the non-therapy ancillary NTA component items, as well as the nursing component. I mentioned several minutes ago that the ICD-10 doesn't apply to the nursing component at all, but some of those checklist diagnoses do. So you want to make sure that you capture those. Now, remember the blanket criteria for coding a diagnosis on the MDS. That diagnosis has to be documented by the physician or the physician extender during the time period of the assessment, but this is the 5-day, so you only got a short window anyway. And that diagnosis has to have that, quote, direct relationship to the resident's current functional status, cognitive status, mood or behavior status, medical treatments, nursing monitoring, or risk of death. I bet you've all got that memorized. Well, it hasn't changed. It's straight from the manual, and that's what you need to adhere to when you're coding a diagnosis on the MDS. So if we look at all of the payment components in PDPM, starting with PT and OT at the top, we've got ICD-10 codes that are involved there. Speech language pathology have ICD-10 codes involved, and the non-therapy ancillaries. So basically everything but the base rate is covered with the diagnoses in one way or another. So I thought I would give you a little case mix example to try to put some of these pieces together, because it really is putting the pieces together to put together a full picture of what is going on with that patient or resident in the facility. So let's start off with a resident. We'll call her Jane. She was admitted for therapy for PT, OT, and speech. She had a CVA. She has right-sided hemiparesis. She has trouble speaking, trouble swallowing. In addition, she doesn't walk currently. She has very substantial or maximal assistance for bed mobility, transfers and toileting hygiene, partial moderate assistance with eating and with oral hygiene. And all those will have meaning in just a moment. Currently, she is taking a mechanically altered diet. She's a puree diet with thickened liquids, let's say, because of the previous stroke. She also has type 2 diabetes, and she has diabetic retinopathy. She's getting insulin every day, and she actually had a couple of insulin order changes during this time span of the 5-day MDS. So, a lot of things getting settled in as she was moving into the SNF. And she's moderately cognitively impaired. So first of all, let's look at what diagnoses we want to make sure that we capture from that brief description. And, there's probably other things that are going on with Jane right now that I haven't thought of, but make sure you're capturing the diagnoses to paint the full picture. So first of all, let's talk about the hemiplegia. So the diagnosis that I came up with when I was going through the steps and looking up the diagnosis in the manual is I69.251. So this is a hemiplegia or hemiparesis following other non-traumatic intracranial hemorrhage affecting the right dominant side. So she was right-handed. So you would code that hemiplegia and hemiparesis, but also don't forget, check off that checkbox, I-4900. Very important for the speech language pathology comorbidity, because that is captured from the checklist. Next, we have the dysphagia, I69.291, dysphagia following other non-traumatic intracranial hemorrhage, again related to the same stroke. The aphasia, I69.220, aphasia following other non-traumatic intracranial hemorrhage. But remember, there's also a checklist item for aphasia, so check that box, I-4300. And let's move on away from the stroke to the diabetes. So type 2 diabetes is E11.3292. So that's a big code. That's all 7 digits. So it's the type 2 with a diabetic retinopathy, no macular edema in her left eye. So it's got the diabetes diagnosis built in. It's also got a complication or a sequela of the diabetes in the retinopathy. A little bit more description: no macular edema, but there is also a code for with macular edema. And where was it? Is it the left eye, the right eye, or bilateral? So all of that is packed into that one 7-digit code. So you would code that diagnosis code, but also remember to check off I-2900 for diabetes. Really important, because that goes into the nursing component. So where does this put us in our little table here of the PDPM components? So first of all, we've got the PT and OT. So I did a little back of the napkin calculation from her description and came up with an ADL score of 7. We'll talk about ADLs in the next webinar. And due to her primary diagnosis of that hemiplegia following the stroke, she's in the acute neurologic clinical category for PT and OT. So with that clinical category and with the ADL score of 7, her component rating is TN. Next, we have the speech. Now, there's a lot going on in that speech language pathology piece. She's got the acute neuro clinical category. Also, all of those things that we checked off: hemiparesis, aphasia, dysphagia, cognitive impairment, swallowing problem, mechanically altered diet. All of these pieces put together with the clinical category and 3 or more comorbidities puts her into the SL category. So those comorbidities add up, because if there were fewer comorbidities, she might be in a lower category. Next up, we have the nursing category. Remember those checks? and checklist. So we've got the diabetes, we've got the insulin in section N, we've got the insulin order changes on 2 or more days. It has to be 2 or more days. Hemiplegia is a checkbox item, remember, so you have to check it off, as well as the diabetes, and an nursing ADL score of 5. Remember, nursing score and therapy score are not necessarily the same thing. So this puts us into more familiar ground because that puts her into a special care high category of HDE1. And then last but not least, we have the non-therapy ancillaries, and that those codes of diabetes with the retinopathy, diabetic retinopathy, plus checking off that checkbox for diabetes gives me an NTA score of 3. If I only checked off the checkbox, I would have an NTA score of 2. And if I only coded the diabetic retinopathy, I would get an NTA score of 1. So you do want to make sure you cover both of those bases here because those NTAs add up, they accumulate. So I hope that made sense. We're actually making some pretty good time here, so there will be time for questions towards the end. Sorry if I'm talking so fast. So let's talk operational strategies. Facilities have dealt with these changes in the past. Again, we had the ICD-10 implementation back in 2015 that people trained up for, but then, frankly, ICD-10 didn't have all that much of a direct impact on RUG-4 reimbursement. So in most cases, there were a lot more priorities that have come up in the last 5 years since then that it kind of slides off the radar screen a little bit. So I think we need to take ICD-10 back out of the closet, dust it off, put it back up on the desk, and focus on it because it's going to be really, really important to ensuring appropriate PDPM reimbursement. So first of all, let's talk about training and making sure that you have at least one ICD-10 proficient coder in your facility. They don't necessarily need to be a certified coder, but somebody who is well trained and well practiced at assigning those ICD-10 codes. So at least one person, multiple people will be helpful just in case that person has a day off, because again, the time is pretty short here. You're trying to capture these codes on the 5-day MDS. If you're a high volume, high Medicare volume facility that has a lot of people churning through that 5-day assessment cycle, you're probably going to need more than one coder in your facility just to keep the workflow going, and you've got coding to do for the rest of the house as well. But at least one person should have a thorough ICD-10 coding training or a refresher if necessary. Now, the other disciplines should also be familiar with the basics of ICD-10 coding because their diagnoses, their documentation helps to drive the specificity of those diagnoses. So things like capturing the laterality of an injury on the MDS, identifying which diagnoses are active versus resolved. That people should be familiar, at least at the basic level, with the basic rules for that. So the type of things that I covered in my brief overview should be sufficient for the other disciplines. Now, I cannot stress enough that you need to use the manual. The ICD-10 CM coding manual is the Bible for this. There are cheat sheets out there. There are ICD-10 code lookups that are built into software. There are websites. There's Google. All very easy, all very convenient. I confess that I've done it in the past as well, but in order to appropriately assign an ICD-10 code, you need to use the manual. You need to identify the primary term for a diagnosis, the main term for a diagnosis, look it up in the tabular list, and then go assign the code from there. So using the manual is very important, and even more important is to always have the current version. The ICD-10 manual is updated every year, as of October 1st. So think of it like your MDS manual. Every year on 10/1, there's an update to the MDS, and the manual is rewritten, and clarifications are added. The ICD-10 people are always adding new codes. They may be modifying codes. They may be excluding certain codes from being used under certain conditions. So you do need to make sure that you always have the current version that is applicable for the time that you're doing that assessment. And if you haven't already, start practicing now and getting into the habit of assigning those ICD-10 codes for at least a subset of your population. I mean, it would be better to ramp up so that when you are prepared as of October 1st, you can handle your whole Medicare caseload. But, you know, start slow, but work up from there. You have several months to do so. Now, you might want to try not just coding for your current and your new admissions to your facility, but take a look at some closed records and do a little spot checking. Look at your current or prior practices and identify any diagnoses that would have been a default diagnosis or an unspecified diagnosis or a return to provider code. What would you have done to capture a more specific diagnoses in those situations? So I think it would be a helpful exercise for you and your interdisciplinary team and maybe your medical director to sit down with one or two closed records and say, okay, let's do an after action review. What happened? What did we code? Could we have done a better job at capturing a specific diagnosis in this situation? And then what systems do we need to put in place to do so going forward? Now, of course, the 5-day carries a lot of weight in PDPM. For probably most patients, it's going to set the payment categories for the entire Medicare stay. If there's an interim payment assessment, of course, that will reset the payment categories in at least some of the components. But really, the 5-day is carrying the weight of PDPM. So that means you have to be able to capture these diagnoses very, very soon after admission to the SNF. This is really, really key to accurately and appropriately coding the 5-day. So of course you will review the hospital diagnoses as well as all of the other transfer paperwork. As I mentioned earlier, just review those diagnoses, discuss with your interdisciplinary team and with the attending physician, and determine if those codes are still applicable to the SNF admission. Make sure that you're appropriately assigning an initial counter versus a subsequent encounter for a specific code, because that would be a difference depending on how you are treating that condition. Again, you want to make sure that the diagnoses are written to the highest level of specificity possible. So those codes can go out to 7 digits. So if you see a diagnosis that the physician has written, congestive heart failure, there's all kinds of ways that congestive heart failure can manifest itself depending on the side of the heart that is affected. Is this causing congestion in the lungs, congestion or peripheral edema rather? So you would want to clarify with the physician and have them write a more specific diagnosis so that you can code the specific type of heart failure in that diagnosis code. Now, remember that there are other requirements that CMS has that are hinged on that 5-day MDS. The SNF quality reporting program is now looking at drug regimen review. Those new MDS items that we started using this October 1st capture drug regimen review at the time of admission or soon thereafter in order to be coded on the MDS. So identifying whether there are any potentially clinically significant medication issues based on the meds that the new admission is receiving. And if you did that DRR and you identified these potentially clinically significant interactions or issues, what did you do about it? So the SNF quality reporting program is measuring or right now measuring whether facilities are doing it and reporting the data, and then they'll move on to actually reporting how facilities are performing. My point in bringing this up is that you're going to have to be doing at least some touching communication with the physician at the time of admission anyway with this drug regimen review requirement. Perhaps if you're putting that system into place now, incorporate a physician diagnosis review along with that, just for the sake of efficiency. It doesn't do any good to call the doctor's office 5 times for the same admission when you could have one to the point discussion where you have a structured system to communicate and follow through with any clarifications or changes that are needed. Of course, before you pick up the phone and call the doctor and get him on a call or her on a call, you want to make sure that you are to the point. So first, identify any diagnoses that you think might not be specific enough and say, okay, can we prioritize these first and see if we can get to a better level of specificity so that I can code the ICD-10s. So just some food for thought here, because as we know, CMS has already put in place regulations that are requiring facilities to address how they're admitting new patients in their facility. And of course, this is all about teamwork. We always talk about teamwork. Well, it's very, very important in this case because no one person is going to do all of this. You need a physician to diagnose, or a nurse practitioner, or a physician assistant. You need a coder to code the diagnosis. You need other interdisciplinary team members to contribute their documentation to contribute to the specificity of that code. So this requires collaboration. It requires communication, particularly when you're sitting down and saying, okay, let's pick a diagnosis. What's the primary here? There might be a toss-up between 2 diagnoses, and the nursing and the therapy department are going to duke it out until they figure out which one should be the primary. It might come down to which gives the most bang for the buck in assigning a clinical category in multiple areas, such as PTOT and speech. So a lot of collaboration is going to be needed. Now, think about your process for picking the ARD of that 5-day MDS, because really the whole framework for ARD selection is going to change as of next October 1st. Right now, we're used to setting that ARD to make sure that we get the most therapy minutes, therapy days and therapy minutes. We love you, therapists, and that's how RUG-4 works. But really, that was what ARD selection has boiled down to in recent years. But think about this again. Take a step back and say, okay, what would be the best ARD to enable my team to capture all the diagnoses and all the comorbidities that I'm going to need to put on that 5-day MDS to fully capture PDPM reimbursement? Remember that 5-day ARD window. There was never any problem with using grace days, but people have always been kind of leery about using them in the first place. Well, grace days are going away. So that ARD window is going to go all the way through day 8. If you need to, use that time to make sure that you are clear on capturing all those diagnoses and comorbidities. Now, of course, later on in the stay, if that resident meets the criteria for an interim payment assessment, look at those active diagnoses, because there might be changes there that would shift a clinical category. So I hope this has been helpful with giving you the perspective of how ICD-10 coding, and by extension other diagnosis coding elsewhere on the MDS, puts together the whole picture of a resident that you're admitting to your nursing home. Of course, we're still taking care of the same people. The people have not changed. It's the perspective that RUG-4 has kind of narrowed our focus down to tunnel vision on the amount of therapy. You know, there are all the other nursing categories in RUG-4, but we all know that the majority of reimbursement in SNFs is driven by therapy days and therapy minutes. But the remaining picture just has not been called out and appropriately acknowledged in the reimbursement structure in RUG-4. PDPM is enabling us to see the whole picture, whether you want to think of it as opening up the tunnel vision to see the vista in front of you, or putting together the pieces of a puzzle to form a whole picture. That's really what this is. You're looking at the complete patient or resident in your facility, and as much as you can, accurately capturing appropriate reimbursement for caring for that whole person. So I like it. I have to say it's a lot of work. It's a lot for us to come to terms with, because it is really changing how SNFs are used to dealing business with their Medicare Part A reimbursement. But I like the fact that we are acknowledging that we are caring for a whole person, and not just the therapy piece of it. Again, we love you, therapists. So I do have a couple of references for you, and then we'll have a little time for questions at the end of the call for a few minutes. Now, I mentioned earlier, CMS just put up their new PDPM website. It's actually good. So as of October 19th, 2018, this is where we will go for updates. The URL is on the screen. It includes some information. There are fact sheets, there are frequently asked questions, there are training slides that are really good. There are also those documents you may have already seen for the ICD-10 to clinical category mapping, the non-therapy ancillary comorbidity mapping. There's the MDS item set changes. That's where we learned about that new item for the primary diagnosis. There's also a whole bunch of new MDS items that are going to be added to capture prior surgery. That would be that'll be another call. So I highly recommend you go to this site, download all the materials, and just soak them in. Now, to take a step back and look specifically at ICD-10 coding, there are official guidelines for coding that are updated every fiscal year. Remember, the manual is updated every fiscal year. Those guidelines are also updated every fiscal year. So the current guidelines can be downloaded at the CMS website. So I highly recommend you pull those and just review the guidelines, particularly for things like coding aftercare and coding sequela and things like that. There are it does explain that process pretty well. And again, you know, get a manual. Any ICD-10 manual, just like any publisher of an MDS manual, will have the same information inside. There may be different formatting that you're more comfortable with or that you're more used to, but please make sure that you invest in an ICD-10 coding manual. Very, very important. Okay, so as I said, we have about 4 or 5 minutes left for questions. I do want to tell you that we're going to take a little hiatus over the holidays, and we will be back in late January. Our next section is going to tackle section GG and those PDPM function scores for PTOT and for nursing. So that's a lot to chew on, because we're so used to the old section G ADL scoring. This is quite a bit different. So we will talk about that late in January. We haven't set the date yet, but stay tuned. You will get the communication. So I appreciate your time today. Now, for getting your CEUs, the process is pretty straightforward. The URL for the SurveyMonkey that you would fill out to evaluate this session is on the screen here. We are also going to follow up this presentation within the next 24 hours with an email that will send you a link to the same online evaluation survey. So either one will take you to the same place. Please complete the survey, fill out your contact information. That's what we need to capture the attendance for this webinar. And please complete it by next Friday, December the 7th. So we'll give you a little over a week to fill out this information. Now, if you're attending this webinar with multiple people, each attendee needs to complete the survey separately so that we can capture the full attendance list. So you can forward that email on to the next person. Now, for nurses, you can download your certificate as you complete the evaluation. You'll get 1 contact hour. For nursing home administrators, we're also approved for 1 contact hour. You'll need to fill in your NAB ID number so that we can report to the NAB CEU registry. NAB now handles all that internally. You can download certificates from their register. Please go to nabweb.org to register if you're an administrator and you're not registered with NAB yet. So that's nationwide. So once we get the completed surveys and attendance list after next week, we'll upload that to the NAB CEU registry and you'll be able to access your information. Okay, well, I've used up almost all our time here. I'm just going to take a quick look to see if there are any questions. So here's a good question. Does the primary diagnosis have to be the same for PT, OT, and speech as well as nursing as it is currently? Well, there is going to be only one primary diagnosis, so you have to pick one. And it's going to go into that I0020B item that's going to be added to the MDS. So you will need to pick just one diagnosis. What's the difference between the SNF primary diagnosis and the primary medical condition category? That's what we already have on the MDS. I'm actually not sure what the difference is. I originally thought that was going to be used, that primary medical condition category was going to be used in PDPM, but it's not. I'm sorry, I don't have the answer to that. I know CMS is doing it for a reason. So let's see here. Here's a clarification. I did mention when I was talking about the diagnosis look-back period, the observation period for the MDS for documented diagnoses is a 60-day look-back period. But what I meant was we are looking at a 5-day MDS for PDPM. So you're not going to be looking back 60 days. You're going to be looking back at the most 8 days. So you don't have to do a lot of searching in the record. That was my point. Okay. So I apologize, there is no time left. If you have any other questions, please feel free to reach out to me or shoot us an email, and I appreciate your time today. So best of luck to you, happy holidays, and we will reconvene in January with our next session. Take care.